Good morning, everyone. We'll start in just a moment. Good morning, everyone. I'm Louise Ivers. I'm the director of the Center for Global Health at Mass General Hospital, and I'm delighted to welcome you all to our shared grand rounds with Mass General Hospital and Brigham and Women's Hospital. It's my pleasure to introduce Professor Vikram Patel, our speaker for today. Vikram is the Paul Farmer Professor and the chair of the Department of Global Health and Social Medicine at Harvard Medical School. He also there leads the Mental Health for All lab. His work is focused on the burden of mental health problems, their association with social disadvantage, and the use of community resources for their prevention and treatment. Vikram is a co-founder of Sangha, an Indian NGO which won the MacArthur Foundation's International Prize and the World Health Organization Public Health Champion of India Prize. Vikram is a fellow of the Academy of Medical Sciences in the UK and a member of the US National Academy of Medicine. We're absolutely thrilled that he's our speaker today. I'll pass to you, Vikram. Thank you so much.
Well, thank you very much, Louise, for inviting me. I am going to start my presentation now. I did try and make sure that I could actually share a video clip with you, but I just realized when I tried to do the share screen that the option that I have for sharing video sound somehow isn't allowing me to click that. So let me, I'll show the clip anyway. And if you don't hear any sound, just let me know, Louise, so that I can then maybe just skip that slide, and when I share the presentation with you after the grand round, people who want to see the video can then access it separately. So it's wonderful to meet you all remotely. I'm joining you from India, where I am spending more than a month now with the various teams that I am engaged with in my research program here. And indeed, some of the work that you're going to hear about today comes from that stable. What I'm planning to do is to essentially take you to 3 or 4 parts of a talk here. The first is very briefly to review why we should be concerned about mental health problems in the global context, then interrogating whether the usual solutions that have been thought about when we consider addressing mental health problems, which is a specialist-led mental health care system, what impact that has had on the crisis. Interrogating what are the alternative ways in which we can address mental health problems, focusing on lessons from the global south, and then ending with how we can scale this up in real world settings. So here is my disclosure statement. I'll just leave it there for a few seconds for you to read it. All right, so very briefly, what is the crisis in global mental health? Firstly, let me just see if I can move this away. There we are. So first of all, if you look at the global burden of disease data, this is a slide we constructed looking at the relative burden of mental and substance use conditions in the 25-year period from 1991 onwards. The key message in this slide really is that the relative burden has increased by 50% in both the richest countries in the world on the red line, as well as in the least resource countries in the world in the blue line. And of course, the difference in the absolute, the relative burden between these two different groups of countries is largely accounted for by the epidemiological and demographic transitions that have occurred in these countries. So there has been an increase in the burden, and indeed, I'll show you later, this is also partly reflected in data on the actual prevalence of mental and substance use conditions. Another very important reason is that unlike most non-communicable diseases, which have become the leading causes of mortality in most parts of the world, mental health problems usually strike in early life. This meta-analysis demonstrates that roughly 2/3 of the entire adult population prevalence of mental health problems has its onset before the age of 25. So this is really a problem of young people. This is, of course, a demographic which generally has relatively good health. apart from mental health. And therefore, if you look at the burden of health problems in young people, you will typically find that anywhere from a quarter to the third of the total burden of health problems in young people is accounted for by mental and substance use conditions. The third important reason is that mental health problems, like many other health problems, are inequitably distributed in the population. This chart comes from the National Mental Health Survey of India, the largest survey ever conducted in India by, in fact, the Ministry of Health and Family Welfare. And there are plenty of charts like this for a full range of mental health conditions that show roughly the same kind of a gradient, which is that the prevalence of mental health problems is highest in the lowest income quintiles and shows a clear gradient to decline as you belong in the richer quintiles. And more recently, with colleagues in the Department of Economics, we looked at the mechanisms through which social disadvantage, in this case, particularly poverty, is associated with mood and anxiety conditions, which are the leading causes of the burden of mental health problems, and found evidence in support of a very complex bidirectional pathway with multiple mechanisms in each of the different arms of that pathway. Really, this also points to the fact that even if we cannot address poverty directly within the healthcare system, there might be things that we could be doing to address some of the mechanisms which can perhaps mitigate the adverse effects of poverty. So this is by way of a very brief snapshot of the mental health crisis, and I really want to spend more time thinking about the solutions to this crisis. But before we do that, I wanted to ask the question, does the kind of a healthcare system that dominates wealthy countries, and particularly the case of the US, which is what I'm going to focus on, does that kind of healthcare system adequately address the crisis? And why would I say that? I'd say that because it is true that a very specialist healthcare system has made very important impacts on a number of disease areas. That is not to say prevention hasn't been important. It's been, in fact, very important. But for those who are affected by, say, cancer or heart disease, it is the case that a biomedical specialist healthcare system has greatly improved the lives of people who are already afflicted by one of those conditions. So let us ask the question, to what extent does the mental health response led by a specialist care system that dominates the US influence the metrics of mental health at the population level? First of all, how well resourced is the US? We often hear in the US that we're under-resourced. But I wanted to just point out in this slide that, in fact, if you consider the single most important resource for mental health, which is mental health providers, and here I'm only looking at psychiatrists. In fact, if you looked at all mental health providers, the richness that the US enjoys is even greater. But if we just take psychiatrists, the US, for its population, has the highest per capita number of psychiatrists in the world. And you can see the largest, the most populous countries in the world in this slide here. And the US is a clear outlier for its population. You can look at countries with similar populations at the bottom of this chart here along the y-axis. What I had not realized is that the US also spends more on mental health care than on any other health condition, particularly if you combine the spending on both outpatient, non-institutionalized populations, as well as institutionalized populations. Of course, the massive cost of mental health care for veterans and active duty military. This is a slide from a somewhat older article now from 2016 in Health Affairs, but I don't believe that the key message of the slide has changed materially since then, which is that the spending on mental disorders completely outstrips all other health conditions. And of course, a large chunk of this spending is on what I showed you in the previous slide, which is on mental health specialists. So what is the impact of all this spending on mental health care? Well, certainly there's been no impact on the burden of mental illness if we consider prevalence as an important metric of burden. If anything, actually, as you see on this slide, which shows the prevalence disaggregated by age bands, that if you look at the youngest age band, which is the blue line here, that actually there's been about a 30% increase in prevalence of any mental illness in this demographic in the last 10 or 15 years. Now, of course, a lot of this could be driven by the fact that risk factors for mental illness have gotten worse, although it has to be said it's very hard to know what those risk factors are. Certainly, there hasn't been a dramatic increase in poverty in the US that can really completely explain this increase in prevalence. And we can turn back to this question a little later in the talk. My focus is really largely not on prevention, but it's going to be on care. If anything, if one looks at perhaps one of the hardest outcomes of any health condition, which is mortality, mortality attributable to mental health or substance use condition has skyrocketed. I'm sure all of you are familiar with the description of deaths of despair, a term that was coined by Angus Deaton and Anne Case. These deaths have mounted in the last 10 or 15 years. Indeed, they mounted so much that for the first time in a century, I think, the life expectancy of Americans has actually plateaued and even declined in certain segments of the population entirely on account of suicide and substance use related deaths. Young people have been particularly badly affected. This is data up until the pandemic, showing that between 2009 and 2018, suicide mortality increased by nearly 50% in those aged between 15 to 24. And if we consider the well-being of people with serious mental illnesses, such as schizophrenia, in the majority of states in the US, there are more people living with a serious mental illness who will spend the night tonight in a prison or on the streets than in any form of shelter that is associated with healing and recovery. I want to end this part of the presentation with a quote from Tom Insel, who is the former director of the National Institute for Mental Health. For those of you who want to read more about the state of affairs of the mental health care system in the US, Tom wrote a brilliant book called Healing, which I'd recommend you to. But this quote really speaks for itself. It isn't only the case that the US has spent billions and billions on care, but the US has also spent billions on research. And in his own words, during this period, every single metric associated with poor mental health has increased, and not by small margins. It's increased really quite dramatically over these two last decades. So Tom really paints a somewhat despondent a picture of his own leadership at NIMH. Tom was a very strong believer in the biological mechanism theory of mental illness, a very strong believer that researching biological mechanisms was going to lead to the sort of dramatic discoveries that we've become familiar to see in other areas of medicine, such as infectious disease and oncology, and that's just applying that particular prism to mental illness would help us come up with similarly magical interventions. Unfortunately, as he looks back on these last 2 decades, he feels very despondent that perhaps they were chasing up the wrong tree. So if it is a case that even the wealthiest countries in the world have failed to address mental health needs equitably, in sharp contrast to virtually every other domain of medicine, we really have to ask the question, what is the reason for this? What have we all collectively, as a body of scientists addressing mental health problems, gotten wrong? Well, this has been a question that has vexed many different groups in the last 5 years. Here I just show you a series of reports from the World Health Organization, which was just last year, in fact, the World Bank, which was a few years ago. These are both World Health Organization reports, and 3 commissions in the Lancet addressing stigma, global mental health, and depression in particular. This has been a topic that literally hundreds of experts drawn from very diverse disciplines have really pondered over in all these different reports. And what I'm about to show you is a synthesis of what is the central reason that all of these reports have arrived at to explain why we have failed to see impact in the way we should have. And in a nutshell, all of these reports come to the conclusion that the real problem lies in the embracing of a very narrow diagnosis-driven model of mental disorders as being the primary way of thinking about mental health problems, even though decades of neuroscience have shown us, indeed, not just neuroscience, every form of science, social science, developmental science, psychological science, decades of all these different scientific traditions have shown us that, in fact, most mental health problems, indeed all mental health problems, really lie on a spectrum. They're dimensional in nature. Many of them are really evolutionary in origin, and that when they occur in the form of clinical problems and social impairments, they're often they're often the result of rapid social change and maladaptive social environments. Nevertheless, this very narrow binary model of diagnosis with a one-size-fits-all approach for each diagnosis has led to the privileging of biological mechanisms over psychological and social mechanisms, a privileging of narrowly defined clinical interventions over broadly defined preventative and promotive interventions, a narrowly defined approach that privileges specialist mental health care over any other form of care, and a focus on clinical phenomena that really dominate the DSM diagnostic system, as opposed to what really matters to people who are living with a diagnosed mental disorder, which is often not related to those phenomena, but is often related to their personal, social, or psychological well-being. About half a year ago, in July last year, myself and a group of colleagues that were involved with a number of these Lancet commissions got together and wrote a policy paper for the Lancet that really sought to examine what might be the lessons from a large body of science that has not fully been embraced in thinking about transforming mental health care systems. What are the paradigm shifts and what are the policy recommendations? We identified 5 paradigm shifts that also cover issues like prevention and human rights. But for the purpose of this lecture, I'm only going to focus on 2 paradigm shifts that are particularly concerned with the questions of who should provide mental health care, when, where, and in what form. The first paradigm shift that we identify is shifting from a focus on clinical interventions, by which we mean biomedically defined clinical interventions that really are dominated by pharmaceuticals, focusing on severe or acute clinical presentations, to a staging model that explicitly acknowledges the dimensional nature of mental health problems and the fact that mental illnesses don't appear overnight in an individual, but that there are sometimes years of evolution from the point of time when symptoms first appear, like I said, typically in adolescence or young adulthood, to the time when they become an acute or severe episode that is brought to the notice of the healthcare system. And what this allows us to do then is to really reimagine how healthcare for mental health problems can be delivered. Whereas right now, most mental health interventions are really focused on acute episodes. And this is just showing you a staging approach for depression. Actually, you could apply the same for virtually every mental health condition, from autism all the way through to psychosis or dementia. And well, some people consider dementia a neurological disorder, but I'm not going to get caught up in those disciplinary disputes. In most parts of the world, there are no neurologists or psychiatrists, and ultimately we have to deal with all brain disorders really as one broad group of health conditions. So here I'm showing you an infographic from the Lancet Commission on Depression, and most of our energies have been focused here. But imagine if we could actually develop and deliver interventions that really focused on pre-diagnosis, early interventions before, in fact, a constellation of symptoms that are impairing reach this acute stage. And this could be really within the broad domain of early intervention or indicated prevention. This is an example of how a stage approach to care for depression can help prevent episodes from actually becoming acute, full-blown clinical episodes. And related to that paradigm shift is a second paradigm shift. This would mean that we shift from a focus on highly trained and expensive mental health specialists as the primary human resource to deliver mental health care. Of course, they do have a role, but the question is, are they the only or the most important providers? To perhaps a much more diverse workforce that embraces a range of frontline providers to enhance access to care and deliver, in particular, interventions that target psychological and social mechanisms. Now, I want to spend the rest of my talk really focusing on this innovation, drawing upon not just my own work, but also the work of global mental health researchers and innovators around the world. Now, in my own work, I have spent nearly 2.5 decades working with a not-for-profit organization that is pretty grassroots in India called Sangat, which works across the country in several states of the country, and has over the last 2 decades become a pioneer in examining how interventions for the prevention of mental health problems, all the way through to promoting recovery across the full range of mental health problems, can be designed in ways that are culturally congruent, that address psychological and social mechanisms, that can be delivered in the moment when people need them, and therefore also can be delivered by human resources that are widely available in the communities that Sangat works in, which is almost always people who are not formally trained mental health care professionals, but typically are lay persons, community health workers, peer support workers, and so on. And here you can just see the titles of a range of different trials that Sangat then conducts to evaluate the effectiveness either in prevention. You can see examples of prevention in school settings from here, all the way through acute treatment for conditions like depression, which I'll talk more about. Here's another example of prevention in older adults, all the way through to more enduring mental health conditions and disabilities such as schizophrenia and autism. Let me give you an example of one such intervention, because the rest of my talk is really going to focus on this example and demonstrate not only how this intervention works, but also how we're currently involved in scaling it up. So this was an intervention that was designed for severe depression. It's a 6-session treatment. I won't go into the details of the 3-year process that we used to actually design a culturally congruent health system and contextually appropriate intervention. But suffice to say, it's 6 sessions. Each session lasts 30 to 40 minutes. It's delivered by a lay counselor in community or primary care settings. The manual is open access. It's called the Healthy Activity Program. And the psychological science foundation of the intervention is behavioral activation. So very important to say that every single intervention that I've been involved with designing has a very robust grounding in cognitive or behavioral science, and those interventions that are targeting social environments have a robust grounding in the social sciences. The intervention was then trialed in a randomized controlled trial involving the recruitment of 495 individuals with severe depression, not mild depression, but severe depression, attending routine primary care settings. Important to say that none of these individuals had ever received a talking treatment before. In fact, none of them had received a diagnosis of depression before. None of them had received any treatment, therefore, for their depression. And we observed adherence rates with the intervention of about 70%, which would make, I think, most people in psychotherapy very happy if people completed the full course of treatment. And I'm going to show you a video now that illustrates this intervention. But Louise, I don't know whether the sound will work. So, if you don't hear any sound, there's some sound now. I don't know if you can hear it, Louise.
Well, we can hear it. We can hear it.
Oh, great.
तकलीफ दुकान आणि चक्कर येल्यासारखीचा डेली तकलीफ दुकान डेली घरातले कसले काम जायना जाऊन दिसत भुरग्यांक सुद्दां आगे गेली कित्याक घरातले करिना जाय म्हाका खूब त्रास करता घरा तेजी बायलूय शिकयता आनी म्हाका खूब टेन्शन जाता तकली हांव बरें नासता म्हाका जेवपाची बी याद येता आनी कितें खावचें कितें काम करचें अशें म्हाका दिसत ना आनी भुरग्यांकूय हांवें सारकें वाडयलें कांय करिना एक कितें करप आनी कितें घातल्यार घालप आनी टायमूच म्हाका असो बसोनूच हांवें काडप म्हाका खूब टेन्शन जाता.
With depression, we've developed a very specific treatment called the Healthy Activity Program. This is a treatment that's based on the concept that when people become depressed, they stop doing activities that they typically do. For example, there may be social withdrawal, they may not be able to keep up with their work demands, they may stop doing pleasurable activities like watching TV, reading, etc. The less they do, the worse they're likely to feel. So the Healthy Activity Program is delivered over about 6 to 8 sessions. So the main focus of the initial sessions is to get patients to become activated, to start doing things that we know will help them feel better.
कितें काम कर म्हणजे मागीर ताणें रोंपो लायलो मातशें अशें भोंवूंक वचूंक लागलें काटयां हाडूंक लागलें शेतान मातशें वचूंक लागलें आनी कितें भाजी पालो घरा कडेन रोवंक लागलें आनी तितून मात मागीर म्हाका म्हयन्यान करून म्हाका एक 9 म्हयन्यांनी सारकें पूर्ण तकली माझी शांत बरी जाली पयलीं तिणी 5 मिनटां कुळागरां वचून काम करून मागीर तेणी म्हाका 10 मिनटां दिली मागीर 15 मिनटां दिली मागीर म्हाका तें काम बरें जाता शें दिसलें हांवें 5 मिनटां 2 मिनटां वाडोवन चलप मागीर म्हाजी भुरगीं येतालीं मदत करून आनी इतल्यान म्हाजें आतां कुळागर निव्वळ आसा आनी म्हाजें कामच चालू बरी जाता आनी म्हाका आतां वखद सुद्दां लागना बरी जाली तितूंतल्यान आनी बरी आसा सामकी
आणि आता म्हाका खूप बरें दिसता तकली जास्त दुखता केन्ना अशें दुखोन दुखता बीन उठपाचें भुरग्यांक शाळेक धाडपाचें म्हाका त्रास जाता तकली ती दुकान घातल्या सारकी.
So the evaluation of this intervention, you can see 3 points of the outcome. Obviously, at baseline, everybody was severely depressed. As you often see, just by giving a controlled treatment of enhanced usual care, where you inform people about their diagnosis, you inform the primary health center doctor who may initiate antidepressant treatment. We found about 60% was still depressed at 3 months. And you find that in the control arm, roughly the same number were depressed at 1 year, and 5 years later, that number hadn't declined very much. But look at the decline in the intervention arm. There was a 60% increase odds of recovery, of remission at 3 months, which was sustained at 12 months. And incredibly, even 5 years later, there are still statistically significant differences in the prevalence of depression. Now, it's important to say that while 2/3 of the individuals recovered and stayed well, a third did not. And clearly, I want to make the case here and clarify, it is that third of individuals who needed the most specialized care that currently dominates the healthcare system in most parts of the world. It is that 1/3 that needs to see the psychiatrists and the psychologists, but 2/3 with severe depression recovered and stayed well for 5 years, with a treatment that took about 2.5 hours altogether in therapy time by a frontline worker who had no prior training in, leave aside mental health, no prior training even in health. Actually, this evidence isn't just coming from one trial. The Healthy Activity Program itself has now been evaluated in large randomized controlled trials in Nepal, for people with HIV in Uganda, and we see the same results in all of these trials. But there's also a large body of parallel evidence coming from other innovators. The picture you see on the slide comes from Zimbabwe, and this is the very well-known Friendship Bench program led by Dixon Chibanda, in which he trained grandmothers in high-density townships of the city of Harare to deliver depression care to women such as this one in the compound of primary health centers, because the health centers are crowded, and also because Harare has gorgeous weather, so you can actually spend most of the year outdoors. And he constructed this counseling bench where there's a sense of privacy for the therapy to be delivered. Like this, there are literally hundreds now of randomized controlled trials that have been synthesized in an ever-increasing number of meta-analyses and systematic reviews, clearly demonstrating that we know how to deliver early intervention, recovery-focused and preventive interventions in any resource setting, deploying resources that every community possesses, essentially frontline workers, nurses, and other forms of non-specialist providers. This has also given us an opportunity to reimagine the architecture of care in low resource settings, and I'd argue this might also be very relevant to high resource settings such as the US. In this infographic, what you can see here is, of course, at the center of the mental health care system must be people who live with mental health conditions. And surrounding them, supporting them, are the community health workers or other frontline workers who have been trained in evidence-based psychosocial interventions. They must be linked to primary care, which should be the nodal center for common mental health problems, for comorbidities and prevention, working with a network of other community-based systems that are essential for prevention, such as school systems. These primary healthcare centers are supported by the well-established system of collaborative care in terms of evidence, with psychiatric and psychological facilities that are typically based in specialist care. And we have also found that it is the specialist care system which really should be the node for care for all people with serious enduring mental health problems. This is where you might have acute inpatient units, liaison with services that are particularly tailored to the needs of people with serious enduring mental illness, and of course, community health workers who directly report to these district hospitals for supporting people with serious mental illness. So again, seeing that there is a nuance and a difference between those individuals who have common mental health problems that tend to be less disabling, less enduring, and those individuals with less frequent but much more enduring and disabling chronic mental health conditions. All of this goes to say that the famous pyramid of how mental health care should be organized, the pyramid that has been widely used in the World Health Organization, should now focus on building the base of the pyramid, the people around, as it were, who are in closest proximity to the families and the individuals who are living with mental illness. Actually, most of the money and the beds currently in mental health care systems around the world has been focused only at the top of the pyramid. And so the real big question is, how do we now move forward with this incredible body of implementation and clinical science that has been built really in the last 2 decades? How do we now scale this up? For me, the question really isn't any longer, is star sharing of brief psychosocial interventions effective? That question has been answered many times in many places. So the proof of replication has been shown repeatedly. The real question now is, how do we scale this up in the real world? So I want to end with telling you about a program that I launched in my lab in the Department of Global Health and Social Medicine at Harvard Medical School, working with partners across the US and also in India, which is really seeking to deploy digital tools to enable frontline workers to learn, master, and deliver evidence-based psychosocial interventions, and by deploying digital tools to really make this happen at a very rapid scale in real-world systems. What Empower is really seeking to do is to converge 3 different strands of science. Clinical science, which is demonstrated, contrary to decades of dogma, that very brief interventions, provided that they are built around clearly defined mechanisms, typically targeting psychological and or social mechanisms, are hugely effective, both for prevention, but in this focus of my lecture is on care for a range of mental health problems. The second body is that of implementation science, demonstrating the effectiveness of the delivery of such interventions by frontline providers in routine care settings. And third, and of course, the third body of science has been around for more than a decade, but the 3 or 4 years that of the pandemic have just transformed the use of digital platforms for training, supervision, and quality assurance. But there's also an entire science base, for example, that demonstrates the effectiveness of digital learning compared to the more traditional in-person expert-led training methods. And that includes some of the work that we've been doing in India. I'm not going to share much of that today, but suffice to say, there are randomized controlled trials demonstrating how digital learning, especially when coach-supported, is as effective as the gold standard of in-person, workshop-based, expert-led training. What Empower then has done is derived a model through which one can accompany. Of course, the word accompaniment, all of you in global health at Harvard would know that this term has been really popularized by Paul Farmer when he really spoke about how we need to accompany individuals living with chronic health problems on the journey to recovery. We apply that idea really to learners, how we can accompany frontline workers on a lifelong journey of learning, mastering, and delivering evidence-based psychosocial interventions. So we've developed this kind of journey that begins with a naive learner who we call the Empower learner, in which the learner undergoes training and then undergoes knowledge assessment on that particular intervention. Then the learner becomes an intern much like I think, medical training, in fact, or clinical psychology training, becomes an intern where the learner masters the delivery of that knowledge through case-based practice with supervision. Then the learner becomes a credentialed provider by undergoing a skills assessment and the triangulation of information that came from the internship phase and the skills assessment that allows one to then be confident that the person is ready to actually deliver care to patients in the real world. And then over time, the provider now becomes an expert by entering the workforce, engaging with peer supervision, and then ultimately graduating over time to become an expert who can then coach the next generation of learners and interns. So this is a kind of an ideal or aspirational model of the Empower provider. And we have now begun to test this model in the real world, as I'll share with you in a moment. Where does technology fit in? Technology fits in 4 different ways. First, through, of course, the deployment of learning management systems to deliver competency-based digital curricula for every intervention. Second, for assessing competencies, both knowledge and skills, but particularly skills through remotely delivered assessments that include both self-recorded or observed role plays that can be rated on psychometrically validated measures. Third, in partnership with the Boston-based tech company Dimagi, which runs the ComCare platform, which I believe is the most globally widely used platform for community health workers, we've designed a bespoke digital app that can be used by frontline workers for case management, for measurement-based peer supervision. By measurement-based, we mean where peers will meet, listen to audio-recorded therapy sessions, provide quantified quality ratings using treatment-specific rating scales, and then also participate in synchronous discussions about their ratings. So this app has been developed, which can now be deployed for really any psychosocial intervention. And then lastly, data science-driven evaluation. If you can see how at every step of the journey that the provider makes, we have digital footprints of their learning performance, their competency assessments, their skills assessments, their quality ratings. And ultimately, of course, this allows us to unpack the entire pathway, the black box, as it were, of psychosocial interventions, to be able to ask very important questions about what aspect of the competencies or quality are most predictive of patient outcomes. And that's useful because it helps us even perhaps become more parsimonious in the training as well as in the skills that our individual needs in order to enable patient recovery. And hopefully in doing that, in feedback loops, enhance the effectiveness of the mental health care system overall. So to end, where are we now in this journey? And I'm only describing one intervention at the moment. So we are scaling up the Healthy Activity Program in rural India in 3 districts of the state of Madhya Pradesh. I'm about to finalize the publication that describes the outcomes of the first 2,000 individuals identified by ASHAs. These are the ASHAs, or the frontline workforce. They're all masked really because all of this work happened during the pandemic. And so these ASHAs were trained on their own smartphones. They have started engaging in peer supervision using the Dimagi app, and already several thousand individuals have been identified through proactive screening by these ASHAs. And we now have data on the depression scores before and after the ASHAs treated these individuals. We have treatment adherence rates that are even higher than what we found in our trial. And I'm very excited to see some of the effectiveness data that demonstrates how this treatment can be effectively delivered in the real world on the backbone of the Empower program. Now, I began my talk about really describing how the US healthcare system could potentially also benefit from some of the innovations that have been championed in the Global South. And I had the terrific opportunity to launch a similar effort in the US in the middle of the pandemic. Before the pandemic began, just a few months before, when we launched the Empower Lab at Harvard Medical School, in collaboration with the American Psychological Association, we began adapting the curricula and the manuals that we had designed in India and had then been adapted in Nepal, Malawi, Uganda, and elsewhere for the very unique context of Texas in the US. And in partnership with the APA, we produced the US English version of the manuals and the curricula for frontline workers in Texas. Of course, Texas also has a large Spanish language speaking population. And so we also have developed Spanish language versions working in close partnership with local organizations that provide healthcare through promotoras. We were very fortunate to have won support initially from the Sergo Foundation to kickstart our work, but then we won the Lone Star Prize in the middle of the pandemic in partnership with the Meadows Mental Health Policy Institute to bring this community health worker model that was developed in India to the US. The Lone Star Prize was actually a surprise to us because it was a prize that was announced to improve the lives of people in Texas affected by the pandemic. And it could have been any idea from water harvesting through to addressing racial discrimination. So we were genuinely surprised when our model of depression care won the prize. And that gave us a real leg up to begin working in the Baylor Scott White Health System, which is Texas's largest health system. To begin piloting the delivery of this intervention, the Empower model with community health workers in the Baylor Scott White system. And just a couple of months ago, we won a UO1 grant with the University of Texas in Arlington to embed the Empower program in the training of undergraduates who are training in social work, which is, of course, a terrific opportunity for us to actually scale up, not through just the existing frontline workers, but the future frontline workers who are currently undergoing training in either social work or, as I'll speak about in a moment, a new generation of child and adolescent mental health counselors who will be trained through undergraduate programs. And so this brings me to my second last slide. We're now working on 4 other interventions in production. The first one, which is most advanced with support from the Manton Foundation, is a transdiagnostic 2-step intervention, starting with a single session intervention, followed by a 3 to 4 session intervention for emotional disorders in adolescents. I work closely with John Weiss in the Department of Psychology at Harvard, but also with the leadership of the Children's Hospital of Philadelphia and the Balmer Institute, which is the one I referred to, which will launch in the fall of this year, the first undergraduate program to train child and adolescent mental health counselors for school and community-based systems in the US. This is led by a former Harvard faculty, Katie McLaughlin. And along with the Balmer Institute, we will be rolling out then, after this work is over with emotional disorders, a suite of further interventions, also addressing substance use problems and externalizing health problems in adolescents. The second intervention production are peer support interventions, focusing primarily on social mechanisms for people living with serious mental disorders. For this program, we're working both in India and the US with a range of global and domestic partners representing people with the lived experience of serious mental illness. The third is on the back of a series of trials demonstrating the effectiveness of parent-mediated interventions for children with autism. We're collaborating with our partners shown on the slide to scale up this intervention in districts in India, Sri Lanka, and Nepal. And ultimately, that will also be done using exactly the same playbook of Empower. And finally, we're just in the final stages of wrapping up negotiations with a donor to design a single session intervention for peritraumatic events, for example, which could be used in A&E settings, in emergency settings, in police settings, for people who've suffered acute trauma. But it could also be used, for example, in climate change events or conflict events, where one of the most important reasons why people are distressed is because of the exposure to acute traumatic events. In conclusion, then, I think it's very clear to everyone in the mental health system that business as usual, which is focused on a very narrow diagnosis-driven model, as important as it is for a subset of people living with mental health problems, it cannot be the only approach that we have for mental health problems at the population level. And business as usual will simply not succeed in reducing the global burden of mental illness. I haven't mentioned anything about prevention, but of course there's a huge scope for prevention as well, which we describe in a lot more detail in our paper in The Lancet. Diverse scientific disciplines ranging from developmental science all the way through to implementation science, as well as diverse grassroots experiences, point to a radically different approach, both to understanding mental health problems and preventing and caring for mental health problems. What's really exciting is that all of these actions rely for the most part on resources that every community and country already has. This doesn't require building new clinics or new, technically sophisticated centers. It actually just simply requires deploying interventions and human resources that are already widely available. The pandemic and climate change are examples of great threats to population health, but particularly population mental health, which have galvanized political and public interest in mental health. And I believe the science that I've shared with you today is ripe for action. The time is now. So thank you very much. And I'm leaving a bit of time now for questions.
Vikram, thank you so much for an amazing body of work and an amazing talk. I think all of us found it incredibly illuminating and truly revolutionary. If folks have questions, please put them in the Q&A or the chat. And I'd love to start with one, Vikram. And if you would, I imagine there's been a lot of resistance from some entrenched interests in this field. Because like I said, this work truly seems revolutionary in some ways. Have you encountered resistance, and how has that been, and what's that been like?
Yeah, Joe, of course, you're absolutely right. But, let's be clear about this. Resistance has always come for any radical, disruptive innovation in global health. I'm inspired, for example, on how community health worker movements around the world have become so dominant in countries like in India. I remember very well when the first randomized controlled trial showing that community health workers could reduce newborn sepsis, pneumonia, and resulting mortality. All the pediatricians in India, none of whom would work in the rural parts of the country where most mortality was taking place, were up in arms. And they demanded the construction of NICUs everywhere in India, which of course was going to be completely unfeasible because there would be no one to staff them. There was a huge pushback. And the innovators, Rani and Abhay Bang, who became iconic figures in global health, they had to conduct a series of subsequent randomized controlled trials to replicate this. So I have to be honest, such pushbacks have often happened. Today, of course, no one questions that evidence. In my own work, it has to be said, when the first randomized controlled trials were published, there were a lot of questions asked. Is this just a flash in the pan? Is this charismatic individuals who are leading these programs? But as the body of trials has grown to more than 100, which involves literally hundreds now of investigators around the world, that critique is no longer holding much water. The question of replicability, the question, is this a charismatic individual, no longer really holds water. The other thing that's happened is that both the APAs, particularly I'd say, the Psychological Association has been, really led by visionary individuals, the Psychiatric Association as well, but the Psychological Association, you'd imagine, would give you the most pushback because the interventions are all in the psychological domain. These are not medication interventions. And it's been a surprise to me, Joe, how utterly engaged the leadership of the APA has been. Their CEO, Arthur Evans, was in fact the head of Philadelphia's community mental health program for many years, and he has himself worked in community settings with grassroots innovations. Tammy Benton, who works in CHOP, which is also in Philadelphia, is the head of the American Academy of Child and Adolescent Psychiatry, has completely embraced the idea that child psychiatrists cannot be seeing every child or adolescent who is struggling with their mental health. Is impossible. So there has been a broader recognition that this approach is not going to take away business from psychiatrists and psychologists. But what this is going to do is, if anything, reduce the burden of cases that psychologists and psychiatrists don't need to spend time with, and allow those of us who've spent decades training to really work at the top of our license. That's really the idea. And I think that has reframed this issue from being territorial competition to really allowing those of us with all this experience to focus on those who are needing our experience, as it were, needing the kind of skills that we bring to play. And so also my presentation has ceased to talk about competition. It's always about collaboration. It's always about expanding the mental health care system to reach the last mile.
Well, thanks for sharing that. And I'm so glad that people are recognize the value of the work. It's incredible. We have one question. Thank you for an amazing presentation. In the video, all the participants were women. Are there cultural barriers for providing community mental health care to men? Thank you.
Well, that's a great question. So I will say yes, to some extent. Primary healthcare in most countries is dominated by female patients. There are many reasons for that. One of them is that primary healthcare centers operate at the same time that men go to work. And of course, less women are in the workforce in many developing countries than men. So that's one reason. And it's a really important question for us to think about the organization of healthcare systems. How do we organize healthcare systems? It seems to be more tailored to the needs of the healthcare providers than the communities we're supposed to serve. The second reason is that depression epidemiologically, of course, is more frequently reported in women. So if you look at epidemiological surveys, usually 2 to 3 times greater prevalence in women than men. And there are many reasons for that too, which we can touch on if you're interested. The third reason is women already come to clinics for many other reasons related to women's health. So, for example, primary healthcare is very dominated by maternal and child health delivery priorities. So, obviously, that means that women and children are going to be the most common demographic. And therefore, when you're identifying cases, you're just going to see more women as well. So, for all these reasons, women do dominate. That being said, in parallel with the depression program, we also were working on alcoholism. And in fact, if you look at that patient population, the overwhelming majority are men. And that reflects, of course, the epidemiological picture that certainly in South Asia, men outnumber women when it comes to harmful drinking or alcohol addiction, literally by 9:1. And so the overwhelming majority of the participants in those trials were all men.
Thanks. Thanks, Vikram. We have 2 other questions. I'm going to bundle them. One asks, I'm curious whether there are any ethical issues of randomizing the community-based interventions you described. And Ruma would love for you to share what led you to your mental health work.
Okay, well, they're 2 very different questions, so I'll answer them separately. So this question is a big one in global health, isn't it? I mean, I remember an editorial by the New England Journal of Medicine editor, Marcia Angel. I'm sure I'm not pronouncing it correctly, questioning the ethics of a trial that was conducted in India in which communities were randomized. In fact, I think it was the same trial I was referring to on newborn mortality. And it is a very complex question. It goes at the heart of the issue, what is usual care? And obviously, people have different points of view. Should usual care, should the control arm be the best care that is conceivable, or should it be the care that people currently receive? And, my own perspective on this is that we cannot not do anything at all, because usual care for mental health problems really is no care. But at the same time, if we construct an artificial usual care by bringing what we consider best quality care, then it, of course, defeats the whole purpose of the trial, which is to really examine an innovative, radical, disruptive way of delivering care. So what we do, the compromise we have, is we will call enhanced usual care, which means this. First of all, we inform the individual of the results of their screening, which has never been done before. So this is way more than what would ever have been done. We provide them detailed information about their mental health condition. We also give them a booklet that describes self-care skills, which, honestly, are very helpful for a large proportion of people. Secondly, we share the information on the diagnosis with the primary health center doctor. We do this in both arms of the trial, obviously. Thirdly, we provide training to the primary health center doctor on WHO guidelines for the prescription of antidepressant medication. We also provide them training on basic psychoeducation. And fourthly, we make sure that fluoxetine, which is the standard antidepressant in the healthcare system, is available in the pharmacy. So we do all of that, but we don't provide them with psychotherapy because that is, in fact, what we're testing in the trial. To the other question about what attracted me to mental health, but that's a long time ago. So it's obviously requires me to recover some memories because I get asked that question very often. I guess some of those memories have been reconsolidated. So really, it was I've always been very, very excited by brain science. That's always been my most the part of the since we divvy up the human body into all these different organs. That's been the part that excited me the most. But back in the late 1980s, when I was training in medicine, neurology was a very, very depressing specialty. It isn't that depressing now, but it was very depressing back then because you had this whole theater of diagnosis. We had no scans back then either. So, you know, those of you trained back in the 80s will remember the neurology diagnostic rounds would always be like a theater with this, all these little gadgets and, these rods and brushes and all those things. And we'd have a beautiful diagnosis. Usually for some peculiar reason, the name of a German would crop up like Friedrich's ataxia. And then, the neurologist would say, all right, let's move on to the next patient because, we'd ask, why? What do we tell this person? So, no, there's no cure. There's nothing to be done. And I found the psychiatrists who had almost no diagnostic precision always seemed to be able to provide some kind of succor, some kind of hope. And I found that hopeful approach, even in the absence of any precision, very much more inspiring. And so, it attracted me. And so I still think psychiatry is one of the most interesting medical disciplines in the absence of really any concrete, pathophysiology for any mental health condition or any curative intervention. We don't allow our patients to lose hope. And I think there is something to be learned from psychiatry. And to this day, I think that's what makes psychiatry very unique amongst the medical disciplines.
Well, thanks, Vikram. We're running out of time, and I can think of no better place to end than with hope, and with the promise of psychology. So thank you so much. That was, again, the work is incredible, and the talk was amazing. Thanks so much for sharing it with us.
Thank you, Louise. Thank you, Joe, and thanks to all of you who joined. It's been wonderful to spend the evening. Well, for me, the evening in India with you all.
Thanks, Vikram. Bye.
Bye-bye.